मौलवी इधर वो घर बैठे जाके इधर मत आए।
शुरू हो गया।
नजर पाकिस्तान में छुट्टी जुम्मे को होगी यार।
हाँ
पाकिस्तान में छुट्टी अब जुम्मे को होगी।
मेरा मुल्क को जिंदगी भर जमा करें
अभी भी है ना कर
मैं दुनिया में आया जमा करें छुट्टी है। हाँ तो एक दिन नहीं है 2 दिन छुट्टी लगा इसमें।
हाँ वो थर्सडे हाफ लीव है और फ्राइडे फुल छुट्टी ऐसी। हमारे भी ऐसे था वाशी में चेंज कर दिया था।
मेरा मतलब ये कभी चेंज नहीं हुआ।
अभी चेंज कर दिया ये इधर। अभी मार्च से
तर्जुमे वाले छुट्टी है
वही दिक्कत बोलेगा
السيشن حقنا متى حيخلص؟ 9:30
और बात क्या
Good morning. Today our speaker is Dr. John Georgi. He's a chief of musculoskeletal radiology department of biomedical imaging, faculty of medicine, University of Malaya, Malaysia. He's an eminent researcher and a president of Malaysian Association of Sport Medicine. You are most welcome, and we are looking for you to speak.
Thank you, Mr. Chairman. Good morning, everyone. And my talk today is an interesting topic because I got involved in this project actually in a very unique way, because as a sports radiologist in Malaysia, I was asked by the Asian Football Confederation whether I could help with overage players playing in the under-17 competitions. So I got involved, and this turned out to be actually a major project. I'm going to share that with you today. So for age determination in football, overage players were suspected in under-17 tournaments. Now you can see clearly, for instance, in these diagrams here, that certain of the players here definitely look much older than the rest of the players. So this is definitely going to be an advantage to the players who are much bigger. And even here you can see there appears to be an obvious age difference. So the problem here is that there may be falsification or manipulation of information about the age of a player. And the age of a player, when they come to a tournament, is verified by using a passport and not looking at any original birth certificate. So this can lead to an issue. In fact, one of the reasons this was found out was at one of the Olympic Games. There were 4 players in one team with the same birth date on their passport. So even falsification was not done very well. In some countries, parents register the birth quite late. We know this, particularly in African countries. So this could be one of the reasons as well. So we had to come up with a strategy of how to see whether we could have some sort of imaging to look at age. Now, we are all familiar with the bone X-rays and age determination using X-rays with Grulich and Pyle, and also Tanner and Whitehouse. Many of these atlases, as we know, are assessing the population we call the white population, and there is no other type of atlas. For instance, there is no MRI atlas of age estimation. These atlases are used mainly where there are medical conditions, which all of you are aware of, and also in the court of law related to criminal offenses and sometimes with immigration. But the issue arises when can they be used for football players or athletes, because there is ionizing radiation involved. So when we look at FIFA, FIFA stands very much for fair play. The suspicion for overage players definitely does exist, and even when we use X-rays, for instance, in the 2002 Under-17 Asian Championship, where we got permission to use X-rays, we found that many players had skeletal age which was over 17 years of age for Under-17 tournaments. The problem is, as I mentioned, this is ionizing radiation. So when we proposed to FIFA that we needed to do a large multi-center trial, FIFA suggested that we use MRI. And so it was agreed that we would have this large study and the study consisted of 498 participants from 4 different countries, including Malaysia. This was the team, and we had to actually look at all these cases together. There were 3 of us that looked at all the cases, and we looked at a majority of 2 as being the consensus. I think all of us know the advantages of MR, so I won't go over this. So the objectives were to offer MRI as an assessment, but to do this we needed to have a grading system, and we wanted to show that MRI would be more superior to look at the distal radius fusion, because instead of being a composite image, we would have different sections that would show the level of fusion. The specific objectives were to study in not all countries, because they did not allow the use of X-rays, but in Malaysia we use radiographs, T1 rated images, coronal, and CIS 3D images. In the other countries they use the T1 rated coronal. So we had to correlate the degree of epiphyseal fusion with the age, and also the main concentration we decided was, initially we wanted to look at radius and ulnar, but we then decided to look at radius. So the sources for discrepancy in skeletal age determination we know, but we found that in the athletes, I think the main reason for discrepancy would be late registration of these individuals. So this was the study. We obtained ethical clearance in each of our countries and universities. In Malaysia, we had 150 participants, and this was the algorithm that we used for exclusion, and this was how we selected the athletes who were of one ethnic authority, that's ethnic origin, who are Malays from 15 to 19 years old. The important thing was that these individuals, these players, had to produce original verified hospital birth certificates, so that the births would have to be from a hospital and not at a home or elsewhere. This was the demographic of the population in Malaysia. And these were the exclusion criteria, and basically, I think you can read for yourselves, basically there should be no clinical disorder or endocrinal disorder that would cause the growth plates to be affected. So once again, this was the algorithm protocol, where we obtained the plain radiographs of the left wrist and also the T1 and high-resolution CIS 3D images. We randomly numbered the bags, and so the readers had no idea which X-rays belonged to which MRI. So, and these were done on 2 separate readings as well. So this was the grading system that we came up with, and there are 6 levels of grading, as you can see, from no fusion to fully fused. So in the plain radiographs, this is no fusion, early fusion, less than 50% of fusion, more than 50% of fusion, almost completely fused, and complete fusion. Similarly, in MR, the same thing, no fusion, partially fused, less than 50%, more than 50%, almost completely fused, and completely fused. So these were the results. In Malaysia, we found that for each age group, the mean grading was higher for the X-rays in terms of fusion than the MR. And I think this would make sense because the X-ray is a composite image. This has an important meaning. That means a player could be fused on X-ray but not on MR. So if we were using X-rays alone, we could be excluding some players who actually were not completely fused. And this again shows the X-ray readings to be higher than the MR readings for all age groups. The intra and observer variation, we can see very good Spearman's correlation for both at 0.9. So in the larger study, here we used again 1 Tesla and 1.5 Tesla magnets, and we looked at the fusion. This was the demographics of the population. And once again, there was high correlation for inter-rater reliability, high correlation between age and grade of fusion, and the very important finding that only one player in the 16 or under 16 age group was graded as completely fused. So we proposed that we could actually use the fact that a person has total fusion for exclusion in the under 17, allowing for the fact that only a very small percentage would be fused. So this diagram shows exactly what I mentioned, that only 1% under 17 would show complete fusion. So this was then proposed and used in FIFA competitions. So we can see in the different FIFA competitions from 2007, as this was implemented, there was a reduction in 2016 to 2017 when each nation had to do their MRIs before coming to the competition, and then we had random selection at the competitions, and the level of those players that were completely fused was reduced to 0. At the IOC, they had to come to a consensus on this approach, and they said that the conclusion was the available methods to determine chronological age in young athletes may not be sufficient, but this current knowledge that we have is that MR allows a reproducible grading of epiphyseal closure. The MRI method of assessment established so far appearing to mature earlier than regional and club players, and they recommended that the use of this can only be used in under 17 competitions, and the usefulness of ultrasound remains unknown. So with this, we were able to actually to come up with a system in which now it is used worldwide. All countries have to do an MR on their eligible players before they come to the competition. And if their T1 coronal images are shown to be fully fused, they are excluded from participating in the Under 17 World Cup and also the Asian Championship. This is also now extended to other sports as well with the IOC ratification. So with that, I just want to mention about our courses. There's information outside about the course that we run. Basically, we like to train fellows before they join your fellowship program in MRI and ultrasound, so that when they join your program, it will be a lot easier for you to teach them. You can see the information outside. Thank you very much.
Thank you, Dr. George, for the interesting topic. Okay, our next speaker, Dr. Neeraj Dubey. He is the Senior Consultant Radiologist at Tech Pod Hospital, Singapore. His talk today an overview imaging of some common sport injuries.
Good morning, everybody. Assalamu alaikum. I thank the organizers for inviting me for this conference, and I thank all of you also for coming here at this early hour to listen to us. What I'm going to talk about is an overview of some common sports injuries. You'll all appreciate and understand that it's a huge topic. Practically any part of the body can be injured in a sports injury. It would be inappropriate for this forum for me to discuss in detail each and every aspect of sports injuries. So what I've done is basically collect a few of the interesting cases that we've seen and some things which can be easily diagnosed by the commonly available modalities, and that's what I'm going to show you. So the history, the earliest reference to sports injury is by Homer, the same person who wrote Iliad in 850 BC, and he talks about a boxing match that was organized in honor of Achilles to honor Patroclus, and the participants in the boxing match, they suffer injury to their different parts of the body, the mouth, the elbow, and these are the names of the two people who were involved in the boxing match. So sports injury is a very, very well known and obvious sort of a problem from antiquity. More recently, if you look at all the different statistics that come out, these are the different statistics. I won't go into detail because that would be a bit too much for this session. And you can see the number of injuries, the various types of injuries that occur, and these statistics are from 2012, so they're a bit dated, but I'm sure if they haven't decreased, they have definitely increased in number because of the number of the people who are more engaged in active sports nowadays, with the general consensus on being fit and healthy. So you can look at all these different type of concussions in different games here, and you can see obviously, I mean, football. These are American statistics, so they're talking about American football and not soccer. Soccer's down here, so you can appreciate, and I'm sure all of you have seen a game of American football. So what a violent game it is. So it's not surprising that there are so many injuries. A few more statistics tell you the number of injuries amongst individuals 25 to 40 years and by gender, so you can appreciate that generally it's males who engage in more sort of violent sports and more contact sports, and obviously suffer more sports injuries. And these other things, the chart down below tells you where and how they suffer in different games. I think this is a very important slide because this tells you finally in the final analysis everything boils down to money, and this is what it costs if you have a fracture of the leg, that much dollars between, and there's different age groups here, so fracture of the arm costs that much, sprains and strains. So it really, in addition to the trauma that the individual suffers, there's a lot of financial trauma also. So that's what probably is more this thing. A few examples here. Previous president, POTUS, he had 12 stitches after a basketball game in 2012. And I'm from India, I'm a cricket fanatic. Unfortunately, this photograph is of a person who sustained a fatal injury. You can see this cricket ball hitting him here just underneath the helmet. Everybody thought the helmet would be a good protection, but Phil Hughes died because of this, and he was facing a fast bowler, which is very sad, of course. This is all the images of that one. This is the Australian captain, Steve Waugh, having a collision with his colleague, that's Jason Gillespie, and a broken nose. These are two Indian players here, both of them going for a catch and having a massive bang up there. This is a very famous picture here. That is the Indian captain, that is Anil Kumble, playing with a broken jaw in a test match in West Indies. And this gentleman here is Mark Boucher of South Africa. That's a bail that's normally put here. When the ball strikes here, the bail lifted up from here, hit him in his eye, left eye, and his career was finished. So you can see the problems associated with sports injuries. I'm sure all of you know that we use most of the normally available modalities, and ultrasound is a very good and easily accessible modality. CT would be excellent if you're suspecting a fracture, and MR is obviously the best, but then it's expensive and not easily available. Nuclear medicine is rarely available. So that's my first patient here, basketball addict, and you can imagine what happens to a basketball addict. They either injure their knees or they injure their ankle. So these are the X-rays. They didn't show too much here, but what are the injuries here? That is an ACL tear. You can appreciate tear of the lateral meniscus, lateral collateral ligament, contusion of the medial collateral ligament, bone contusions, and edema. So obviously plain X-rays did not help much, but when you did an MRI, saw all those different things. You had contusion of the patellar ligament and a joint effusion to boot. So you have to be careful, and you have to tailor the investigation to the question, the clinical question on hand. You can't use blunderbuss therapy. You can't jump onto an MRI straight away. Try to tailor the investigation to what is the need. Now this basketball player is definitely going to have problems when he lands. Look at the way he strapped his knees, and that's what happens to the ankles. You can have a posterior impingement syndrome and osteogonum syndrome. That's in running sports here. And you can have all these problems. Anterior impingement is very common because after some time in a young individual, they start complaining of ankle pain, and they're just about 23, 24 because they've been playing these active sports, and this is what you develop. That's anterior osteophytes and impingement. This is what happens in long distance runners. You get these transient bone edema here on the tibial plateaus, transient bone edema. And in fact that's quite painful, so they really need to hang up their boots for some time before they can take up long distance running once again. This is a cricket injury. That's a pivot shift injury. You can appreciate the tear of the anterior cruciate ligament. It tore with a snap, and this was with the feet firmly fixed on the ground. The player went to fetch. He picked up the cricket ball and tried to return it back to the wicket keeper. So he did an almost complete turn. He did a 270 degrees turn with his feet firmly planted on the ground, and the anterior cruciate ligament snapped. You can get a trigger finger in golf, and you can see this is the line diagram showing a trigger finger. And what I have is a video here which will show you a snapping that will occur here. When it goes back, you can see the snapping that takes place. That's a thickened pulley here. You can see it goes back with the snap, and that's a trigger finger problem that can occur with people who play golf. If you do a lot of push-ups and you do, you pumping iron and push-ups and etc., you got to be careful of your pectorals. This patient came to us with a suspicion of biceps injury, and we did an ultrasound, and we found that there's a lot of injury here in the pectoralis major here. So that is what happens. You have to be careful when you're doing push-ups. You've got to be careful, and you need to be aware. And this sometimes presents with similar symptoms, exactly similar symptoms as a shoulder injury, and you might be surprised to see a pectoralis injury. So tennis elbow is very common. Everybody knows common extensor tendon there. That's the area that gets injured on the lateral aspect here. And when you do an ultrasound, you do this one, and you can see an area of decreased echogenicity here. And when you go on to the next ultrasound, you can see a lot of increased vascularity. So this is the thumb. This is a very common injury here, increased vascularity. So this is lateral epicondylitis, and it is very, very nicely amenable to prolotherapy. In fact, one of our colleagues had this, and we gave him some prolotherapy, and he really improved a lot. You can tear your biceps when you do pull-ups, and that's what happened. That's the biceps anatomy. It's got two heads proximally and one distally that goes on to the radiotuberosity, and you can get a nicely demonstrable injury here. And what you can see is the absence of the a dead break in the biceps tendon here that you can appreciate here. So you have to be careful, and obviously a clinical history is very, very important, so that you know that this is what I'm looking for, and you focus in that area. That is the okay. So in badminton too, it's a sport which requires a lot of running to and fro and a lot of sliding. So you can imagine the amount of stress that you put on your knee. And a very common injury in badminton is an ACL tear. This was a national, sub-national badminton player, and he had a tear of the anterior cruciate ligament. That's very nicely visible here. So in this patient, we did an MRI and got the answer straight away. Runners suffer a lot from Achilles tendon problems, Achilles tendonitis. You can have a lot of inflammation, you can get a tear, and then of course if it's very, very chronic, what you get is you can get a lot of calcification, and then it's practically impossible for you to run. So you can see this dense calcification here and a diffusely heterogeneous appearance of the Achilles tendon. This patient did not suffer from a tear, but then he had all these other problems and he couldn't practice, he couldn't do too much of running after this. So even though we gave him injections and everything, but it wasn't much helpful. So you can get this, and you can look at the amount of increased vascularity here and the inflammation that this patient suffered, and so he had to give up with this. In addition to direct Achilles tendon injuries, patients or athletes who do a lot of long distance running can suffer from retrocalcanean bursitis, and that can be a very problematic thing, because it's a very tiny bursa there, but when it gets inflamed, we just can't do any more running. So this is another injury. You look at it in Singapore. A lot of young people have to do national service involving a lot of jumping, etc. And what this patient has got, he got pain at the lower aspect of the inferior aspect of the patella, and what he's suffering from is a jumper's knee. So obviously you need to have a period of rest before you can start undertaking vigorous sort of military training here. High impact sports result in tenosynovitis, and this is a tenosynovitis of the posterior tibial tendon that occurred here. You can appreciate a bit of swelling here and some amount of fluid. And when you do a Doppler ultrasound, and you can see a lot of vascularity here. So this patient suffered from posterior tibial tenosynovitis due to impact sports, and that's the diagram. That's where you have problems here: Achilles tendon, running, and everything, etc., etc. Medial gastrocnemius, tennis leg, push-off sports. Push-off sports are the one I just showed you, when you have to take off against a support. So there's a lot of stress that occurs on the medial gastrocnemius, and you can end up with a tear of the medial gastrocnemius if you look carefully here. As you go proximally and you come in the region of the gastrocnemius, which is very common here, you'll suddenly see something coming up here, and that's the area of injury. That's the area of injury that will be coming up here. You can see a lot of decreased epigenicity in this area. So push-up sports result in a lot of, because it's a sudden force and pressure that you give on your medial gastrocnemius when you take a push for let's say a 100-meter dash or something. This is just a transverse section of the same patient, and obviously an unrecognized injury here. You have to be very, very careful. Always start off with the simplest examination here. This is myositis ossificans. Nobody took the trouble of taking a plain X-ray. This patient had myositis ossificans, came straight away for ultrasound, and if we'd just taken a plain X-ray, we would have probably got the answer straight away. So have to be careful. Simple things require simple investigations. This is a supraspinatus tear, very common to everybody. Tears are very easily diagnosable. The problem comes in when you have some, chronic problems, pain, and it's not exactly a tear. That results in supraspinatus tendonitis, and you don't get to see too often. You don't get to see this amount of vascularity here. So this was a patient who was having tendonitis of the supraspinatus. He was a tennis player, so overhead service resulted in a lot of problems in his shoulder, and finally we got to the root of the problem, and that was due to a tendinosis here. This is a middle-aged male having just going for an evening walk. Like I told you, a lot of awareness nowadays for doing, trying to be fit and being in sports. So this was something which occurred here, and minor stumble resulting in a large and huge vastus intermedius tear. So you can appreciate the tear of the vastus intermedius here. And it's just a minor stumble, but that's also considered sports, because even walking briskly is a sport and everybody wants to keep fit. This is something which came in with a lot of fanfare a few years ago, elastography, but unfortunately, probably, at least in my experience, and I'm sure in the experience of other people, it has not lived up to its promise. This was supposed to be a prospective, help for you to diagnose tendinosis. You can see this area of brown here is supposed to be telling you that there's tendinosis, and you can see the 2D images are not very informative. Unfortunately, it hasn't, really got into MSK radiology in a big way. And just the last few slides here. This is a middle-aged individual, over-enthusiastic jogger. This is what happened, and these are MRIs of my knee here. I had a lot of problems. I had to rest. And last but not the least, You can use ultrasound for guided injection. This patient had needed a biceps injection because of bicep tendonitis from weightlifting. So this is what we did, and that's, you can see the needle coming in here, and you can give the inject it into the biceps tendon sheath, and the patient was relieved, and he was quite happy after this treatment. So what I want to say is, sports injuries, you can injure every.
Is Dr. Fatma Abdullah Abdurrahman. She is a consultant radiologist, and she's a consultant musculoskeletal imaging, and she's a prominent musculoskeletal radiologist and imager in the Gulf region.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody, and thank you for the organizing committee for the invitation. I will be talking about pubic pain in athletes. Pubic pain in athletes is quite a common complaint, whether in professional or recreational athletes. And there is a wide differential diagnosis which involves in this complaint. We need to know three important things, whether this is due to athletic pubalgia, which I'm going to talk today, or it is due to repair pain from the head and socket joint, from the hip joint, or due to other visceral or urogenital problem, or any other intra-abdominal or pelvic problem. So athletic pubalgia is a syndrome of musculoskeletal and myotendinous and osseous injury around the pubic symphysis. It can be of chronic, usually it is of chronic nature, but it can be acute and chronic. It is usually unilateral, or it can be bilateral as well. Due to the wide range of differential diagnosis in this area, proper physical examination, history taking can be helpful. Pain or upper thigh pain, or at times it also presents as hip pain, and that's why there is a wide range of differential diagnosis. Unfortunately, it can lead to absence from working or from practicing, and sometimes it leads to early retirement from the sports life. So what I'm going to go through my talk is I will touch base on important anatomy about this area, MRI imaging techniques, and different injuries patterns that can occur here. We'll talk about the secondary cleft sign and the differential diagnosis and other pelvic injuries that can present with similar complaint. So basically speaking, we know that the pelvis is composed of two innominate bones which joins anteriorly by the symphysis pubis, which dissipate the injury, the pressure posteriorly into the sacrum by the sacroiliac joints. The symphysis pubis anterior, it is an amphoerythrodial joint, and it allows only minimal movements. So the symphysis pubis is joined anteriorly by the fibrocartilage. These bones are covered by hyaline cartilage. Normally, we can see bright signal intensity within the symphysis pubis, which is called the primary cleft sign, and which is a normal finding. Anteriorly, there is a very important structure, which is called the fibrocartilage plate, through which the other aponeuroses from the anterior abdominal wall and upper thigh muscles, they attach to. So these we usually start because of the wide range of differential diagnosis with large field of view imaging, and then we zoom into the pubic region. This is the line of the axial oblique imaging, and it is along the iliopectineal line, and it's from the upper surface of the symphysis pubis to the sacral promontory. So that's what we can do it. We can take it from the sagittal topogram, and we draw this line for the axial oblique. We can also do the coronal oblique, which goes along the axis of the symphysis pubis, and of course the dead axial and the sagittal oblique. I depend a lot on the axial obliques and the sagittal to get most of the radiological findings. The rectus abdominis muscle, the aponeurosis or the tendon inferiorly, and it decassate with the tendon of the common adductor tendon. And when we are looking at the common adductor tendon, it has like a triangular appearance. Whether you're looking at it in the MRI or even ultrasound, it has this smooth triangular appearance. These are the images that we can get from the coronal oblique. We'll come across this when we're looking into pathologies, but these are the rectus abdominis muscle, which has both medial and lateral head, and then they fuse with the pubic tubercle. This is important that we follow them section by section, because we can have chronic injuries of these muscles, and it will only show us an MRI as atrophy of this part of the muscle. This is about the midline, and here we can see nicely the fibrocartilage plate anteriorly, which decassate also or the attachment of the aponeurosis of the rectus abdominis and the common adductor tendons. The symphysis pubis, this is close to the midline, and we can see we don't have any bright signal intensity separating the bone from the fibrocartilage. The first two cases are actually ladies. I should mention that these core muscle injuries are more common in male, but they can happen also in female, and the reason for that is men are involved in much forceful injuries, plus the pelvic anatomy in female, the differences that we have, it can be a little bit protective to us. So this lady, she's having a growing pain for 3 months, and we can see here that there is diffuse edema within the symphysis pubic bones bilaterally. We can see posterior bulge of the intersymphysial disc, periostitis edema within the periosteal region, plus strain of the adductor muscle. She's a cyclist. This is the coronal oblique image, and it shows us nicely the long axis of the symphysis pubis and the disc, and we can see here slight irregularity of the cartilage of the cortical margin. The anterior ligament, and anterior to it will be the fibrocartilage. Normally we can at times see a bright signal intensity in the interphysial disc, which is a normal thing, but we should not see the secondary one. And we can see here also that the signal abnormality is traversing from anterior to posterior. This is another case. She's a 45 years old cyclist lady, and she's complaining of bilateral hip pain, but the hip was actually absolutely normal. What we can see here is irregularity and resorption of the articular surfaces, subarticular edema, periostitis and edema within the adjacent soft tissues. And these are some more chronic changes: irregularity of the articular surfaces, subchondral cystic changes. These all comprise changes of osteitis pubis. This is another patient which shows us the changes that can occur with time. These are the acute changes: edema bilaterally within the symphysis pubis. The bright signal intensity is the primary cleft side, which is a developmental change and is normal to see it. But then with time we can see more resorption of pain, of bone, irregularity of the articular surfaces, subchondral fatty replacement, osteophyte formation. Now this is a patient who experienced sudden onset of right groin pain while he was exercising in the gym, and we can see here this is the attachment of the left common adductor tendon, and this is the right common adductor tendon, and there was a gap, and there is a gap and displacement of the tendon proximally, and fluid-filled gap is seen here. And this is the left common adductor tendon, which is again not absolutely normal. This is the normal appearance, the smooth outline, but this has a heterogeneous signal intensity in keeping with tendinosis. These are the sagittal images, and it shows nicely the rectus abdominis, and this is the avulsion injury of the common adductor insertion, the fluid signal intensity, and the strain within the muscle. This is the left side, which shows a bit of irregularity and shows also some increase in signal intensity in keeping with tendinosis, but there is no tear. This is a professional basketball player, and he's actually the captain of the national team in Bahrain, and he had avulsion injury again of the right rectus femoris muscle. The displacement was by about 1.3 centimeter, fluid-filled gap, and bright signal intensity. There is also striping of the adjacent pectineus muscle and a strain edema of the muscles. Plus, due to the acute nature, there is reticular subcutaneous edema within the adjacent soft tissues. This is the attachment of the common adductor on the left side. The patient was intensively treated by conservative therapy, no surgical intervention, and this is 6 months later. We can see the tendon here with some residual changes due to the previous injury, but otherwise we don't see the bright signal intensity, which was due to the displacement and the tear. Patient was asymptomatic at this time, and after 6 months he was gradually introduced back to exercising and playing. So the avulsion injuries or tears at the attachment of the tendon, they are seen either at the tendinous attachment or the common adductor rectus abdominis aponeurosis, and they will be seen as a fluid-filled gap separating the tendon from the underlying bone. Here I'm just copying the clinical detail that I got for this patient, just to give you an idea how sometimes the physical examination might not be really so accurate in pinpointing the examination or the etiological factor. This patient presented with right hip pain for a few months, tenderness over the symphysis pubis, pain while cuffing and walking for long distance, and MRI was requested to rule out hernia, symphysis pubitis, or psoas tendinitis. So in this patient, we can see a curvilinear line. It's different than the other patient when we've seen the detachment of the tendon and the fluid-filled cavities or gap. Here we can see a curvilinear line, which is separating the tendinous attachment from the symphysis pubis. And we can see here the bright signal intensity, which is called the primary cleft sign, but this is called the secondary cleft sign, and it is undercutting the aponeurotic attachment. Again, we can see it here nicely. This is the bright signal intensity undercutting the aponeurosis, continuous with the symphysis pubis. He has a little bit of posterior disc bulge, and these are the sagittal images, which I really love and show us very nicely the curvilinear line at the undercutting the attachment. And these are like peeling injuries at the aponeurotic attachment to the bone. This is the erythrogram. I never actually performed erythrogram for the symphysis pubis, but when we inject the symphysis pubis, we can normally see the vertical line in between the within the symphysis pubis, the fibrocartilage. But when we see this seeping of the contrast material antero-inferiorly, then this is suggestive of secondary cleft sign, which usually indicates that there is periosteal avulsion. So this is another example of the secondary cleft side. We can see it bilaterally on either side here, and these are the sagittal images, bright signal intensity, fluid signal intensity, undercutting the aponeurosis. And these are micro tears at these regions. Another patient, this patient presented with right hip pain for a month and history of a trauma while playing, tenderness over the rectus femoris, and MRI to rule out muscle injury. The rectus femoris was absolutely normal, and again we can see the primary cleft sign, the secondary cleft sign, and we can see strain of the adjacent pectineus muscle. Again, one thing that we can notice here, that the bright signal intensity within the pubic bone is actually anteriorly and inferiorly at the attachment of the aponeurosis and the tendinous attachment, and this is the strain within the muscle, and here we can see the secondary cleft sign. This is a football player, and he's complaining of pain and tenderness over the right adductor insertion for 4 months. And it increased more recently, so they wanted to rule out muscle injury. So this is a more anterior image, the pubic bones, the symphysial fibrocartilage, the fibrocartilage plate more anteriorly, which is a little bit more increase in signal intensity. But when we go to a more posterior image, we can see that we have a small defect at the insertion of the common adductor tendon, and now we can see clearly the partial tear of the tendon. The fibrocartilage is actually a little bit heterogeneous in signal intensity due to the degeneration. And again, here we can see the tear more clearly, plus the strain of the adjacent pectineus muscle. Again, here this is more posterior and shows the short adductor muscles, and nicely we can see the edema, plus some changes within the symphysis pubis as well. So this is the right side. We can see the thickness of the common adductor tendon, the bright signal curvilinear line, the strain of the muscle, abnormal appearance of the tendon. This is the left tendon, and we can see that it is thickened, heterogeneous in signal intensity in keeping with tendinosis. This is the normal appearance of the tendon, the triangular appearance. Another example, the primary cleft sign, the secondary cleft sign, the edema within the symphysis pubis, the posterior disc bulge. That's what I mentioned earlier about the chronic injury of the abdominal wall or the rectus abdominis muscle, and here we can see when we go down, these are the coupled recti, and when we go down we can see that there is atrophy of the lateral head of the rectus abdominis muscle due to an old injury. There is no edema since it is an old injury. Some other avulsion injuries or injuries.
Excuse me, Dr. Fatima, just 2 minutes remain.
So we're going to run through these cases. This is a recreational athlete complaining of right groin pain, and we can see the bony exuberance here, and that was a bony avulsion of the anterior inferior iliac spine. The tendon otherwise was normal, and there is a strain of the muscle. This is another case which has a strain at the myofascial junction of the iliopsoas muscle, and inferiorly the muscle is strained and edematous, plus the joint effusion. This patient is a case of old injury to the pelvis through which he had fusion after that of the right sacroiliac joint, plus he had avascular necrosis of the femoral head, but now he presented with more acute pain, and when we did the MRI, now he has a new area of increase in signal intensity at the femoral neck and the trochanteric region due to stress-related injuries. No fracture line was seen during this examination, and we see here the strain of the adductor muscle and the pectineus. This is another patient. He's a quite young, 19 years old, and he complains of generalized pelvic pain and bilateral hip pain and difficulty in moving. Recently, he joined the military and he was involved in a lot of activities. So he had multiple insufficiency fractures in the right hip and the left hip and the acetabulum, and also in the sacrum posteriorly. We investigated him for calcium profile and vitamin D, and he had very low vitamin D levels, so these are insufficiency fractures in this young athlete. And in conclusion, so the athletic pubalgia is a very important clinical syndrome with complex anatomy that we need to properly see. And it primarily involves the myotendinous attachment or the osseous attachment, and MRI plays a key role in the investigation of this patient and guiding us to the exact anatomical location. Thank you very much.
Thank you, Dr. Fatma, for that interesting topic. Our next speaker is Dr. Adnan Sheikh. He's the Associate Professor of the Radiology Department of University of Ottawa, Canada. He's a Medical Director of 3D Printing, and also he's the Program Director of Emergency Radiology. Dr. Adnan Sheikh, also he's a treasurer for the 3D Printing SIG group at RSNA, and he was my fellowship program director at Ottawa Hospital. I'm so happy to introduce Dr. Adnan Sheikh today. His topic today will be muscles imaging. So welcome, Dr. Adnan.
Thanks, Walid, for the kind introduction. I'd like to thank the organizers for inviting me back to Saudi Arabia. Thank you, Dr. Khalid Ismail, for your hospitality. It was a pleasure for all the things you've done for us. Thank you. So let's talk about muscle imaging. As you know, muscle is the largest, this is my disclosures. As you know, muscle is the largest organ in the human body. It constitutes about 1/3 of the body weight. And if someone is like this, it constitutes more than 50% of the body weight. Just a disclosure, that is not my picture, okay? So muscle, what does it do? It gives you stability and power. It helps you gain stability and power. If you look at the muscle anatomy, there are multiple muscle fibers which coalesce to form a muscle bundle. And for that, and then it has an outer covering which is called the epimysium, okay? And this epimysium is important structure because epimysium can tear. When epimysium tears, what happens is you see this fluid within the perifascicular space. Whenever you see perifascicular space edema or fluid in the setting of trauma, think of epimysium injury. That's the important thing. Clinically, what happens, like what does the epimysium injury contains? It contains blood and hemorrhage. So what happens if you see these patients clinically, you see that these patients have ecchymosis, okay? Case here of patient with pectoralis tear and ecchymosis going on there. Conicyclotrochlearis seen in the elbow. Here the retinaculum is the cubital tunnel retinaculum, which forms the roof of the cubital tunnel, is replaced by this accessory muscle. What does the accessory muscle do? It causes increased pressure on the adjacent neurovascular structure. You see the ulnar nerve there, it's thickened, it's got high signals, so there is ulnar neuritis. The other thing which can happen, this is another example, common thing in the foot. There are multiple accessory muscles you can get in your ankle and foot. Luckily, we imaged the contralateral side. You see there's an accessory muscle there, which is called the flexor digitorum accessorum there. So the thing is, you compare that with the others, compare that accessory muscle to the other muscles. Similar signal, no signal alteration. The signal characteristic is similar to a normal muscle. But the importance of that is the location of that muscle. That muscle is located within the tarsal tunnel. What can it do? It can cause impingement or mass effect with the tarsal tunnel structure. So that's why it's important to understand the abnormal structures. The second thing we're going to talk about is muscle edema, like pattern of muscle pathology. So differential diagnosis again is trauma, DOMS, we'll talk about that in a minute, subacute denervation, rhabdomyolysis, as well as vascular insult. So this is an example of a muscle denervation, a subacute muscle denervation. Secondly, the quadrilateral space syndrome, and the quadrilateral space is where, the quadrilateral space is where the axillary nerve resides. So if there's any mass lesion going on there or injury to the axillary nerve, you can get the symptoms. You see on your fluid sensitive sequences, you see high signal with minor as well as the deltoid muscles, whereas on a T1 you see there's minimal muscle because that can undergo denervation. Let's look at some cases there. So this is the first case, and this is the clinical history. Thigh mass, no pain. Okay, let's make it more interactive. Any diagnosis? No? What's that? Very good. That is muscle hernia, right? So let's see what are we looking at. First of all, look at the signal T1, and then you have a fluid sensitive sequence there. You don't see any signal alteration. What is abnormal? All right, mouse works. Okay, so what is abnormal? You see this muscle, the vastus lateralis there, it has a bulge. Why does it have a bulge? The overlying fascia is torn, that's why the muscle herniates. And that's what is muscle herniation. So muscle herniation, common problem, especially older guys like me. We try to do, we try to keep ourselves young and fit, like we compete with people like Walid. So that's why we keep ourselves fit, and we get all these problems. And also the most important thing is, as I've grown older, I want to lose weight, and whenever I lose weight, I feel some bumps coming up. So that's something which happens, and that's the most common history you get. Patient loses weight, and then there's a new bump which comes, and they come in for MRI. So if you're thinking of muscle herniation, the best exam to do is an ultrasound. The dynamic assessment of the muscle herniation helps you. It helps you to assess the muscle herniation. You can see the muscle protruding out and then reducing back. Most of these cases in muscle herniation, they're asymptomatic. Sometimes you can get some burning, some symptoms there, but most of the time they're asymptomatic. Okay, let's look at another case, 60-year-old male with history of rule sarcoma. So what do we see here? We see that in the Agssr images, first thing you see, there is loss of volume of the rectus femoris. If you see on the sagittal images, you see that edema within the muscle, and the distal tendon is absent. And that space is replaced by fluid or fluid signal there. So the diagnosis here is a distal rectus tear. So when it comes to muscle injury, if you look at the demographics, in older individuals, there is tendinosis, AS, anterior inferior iliac spine, that's why your rectus comes out for. And the third point where you have to look for is your anterior superior iliac spine, that's where the sartorius originates from. Okay, so those are the three spots you have to look for if you're dealing with pediatric population. So this is the MRI, again confirming the avulsion there. So avulsion injuries in adults above 40 is rare, very, very, very rare. If you see an adult with an avulsion, especially a lesser trochanteric avulsion fracture, until it is proven, it is metastasis. So this was a case of lung cancer. This was the first presentation, unfortunately, and this was how this patient presented. So let's look at muscle, how this muscle looks like, the injuries look like. This is grade 1 injury, where you see the architecture of the muscle is normal. But what do you see? In the myotendinous junction, you see that high signal within the muscle as well as peritendinous edema. In grade 2, you see there's increased fluid distortion of the architecture. The longer the fluid, the higher the grade of injury. And that, in addition, again, you see that the fluid in the perifascial space, so that this patient also has an epimysium injury going on there. In grade 3, very easy to diagnose. Right from the back of the room, you can tell that there's a full thickness tear. You see the tendon is torn, retracted, and the tendon site has been replaced with fluid and hematoma there. Anabolic steroids, right? There are people who take anabolic steroids, again, especially the younger generation, who want to look fit like Arnold Schwarzenegger, but that has some complications with it. So what does anabolic steroids do? It stiffens the tendon. The other thing which it does is there is compensatory hypertrophy of the muscles in relation to the tendon. So what does that do? That causes increased overload on the tendon, resulting in tendon tears. So this was this was an example of a pectoralis tear in a patient with on anabolic steroids. Okay, I've got 5 minutes. Let's look at some other cases. So this was a sprinter who came in increasing pain post-activity. Any diagnosis? Rhabdomyolysis is not the right answer. Anyone else? No? Let's go back again. So this is, I said, it's a sprinter. He came in. Look at that. Sprinter. Anterior compartment of the calf there. It's edematous, swollen. In addition, you see one other important finding, that is this one. You see the anterior fascia there? That's thickened. So you know that this is a chronic thing which is happening most likely post-exertion. This is compartment syndrome. You can't miss compartment syndrome. can't miss compartment syndrome is because if you don't treat it with fasciotomy in certain patients, you can get myonecrosis. Okay, so this is especially similar findings, muscle edema all around. But the most important thing here is there is also skin changes. You see subcutaneous edema changes, and if you if you clinically examine this patient has changes within the skin. So this is a case of dermatomyositis. Both dermatomyositis and polymyositis are idiopathic myopathies. Okay. Important thing here is they are not imaging the patient to get a diagnosis. They're imaging the patient to know the extent of the lesion. Okay. So the thing you need to do, you need not worry about spatial resolution. You can image the patient with thicker slice block, like 10mm blocks, and look for the extent of the disease. Other most important thing, whenever you're dealing with a patient with dermatomyositis, they're more prone for soft tissue sarcomas. So keep an eye for those soft tissue sarcomas and look for soft tissue sarcomas in cases of dermatomyositis. I think I will end there because I'm over 15 minutes. I thank you for your attention.
Thank you, Dr. Adnan, for your nice lecture. Our next speaker is Dr. Farah Prest Fimwira. He's a prominent Indian radiologist with interest in musculoskeletal imaging.
Good morning. Today my topic is evaluation of traumatic brachial plexopathy. So we have, as in the previous lecture, we saw the muscle fiber concentration. The nerve is also similar, with the axon covered by endoneurium and few axons forming the fascicle covered by perineurium and the fascicles covered by the epineurium. And why I'm showing this slide is now the imaging is developed to such an extent that not only we are going to see this whether the nerve is in continuity or not, nerve injury with continuity or not, and also with high resolution MRs with the 3T and 7T, you're able to see what the component of the nerve which is going to be injured, whether some fascicles are involved or total nerve involved, and I hope in future it goes up to the level of the axon. So the various areas the brachial plexus can injure here, the postganglionic, it can be injured here, it can be injured here, it can be injured here, at the dorsal root or ventral root. Depending upon that, the patient is going to present the symptoms. Sensory symptoms, if there is injury here, the preganglionic, proximal to the dorsal ganglion, and motor symptoms only if the injury is here, or it can be injured at the exit zone from the spinal cord or within the spinal cord itself. So we need to evaluate from the spinal cord to the most periphery of the brachial plexus. So broadly, I'm not going to the detailed anatomy of the brachial plexus. Broadly, we divide into supraclavicular, retroclavicular, and infraclavicular plexus. Where supraclavicular has the roots and trunks, retroclavicular have most of the divisions, and infraclavicular has these cords and nerves. So broadly, we can divide this brachial plexus. I'm not going to the details of the anatomy of the subclavian triangle, scalene triangle, or retroclavicular, retrococcate tunnel, all these things. It's beyond this scope. My data set is like this. Usually, if you try to do this coronal oblique images, supplemented with oblique axial stir, and most important sequence I use is star MIP sequence, taking the 3D and putting into a MIP, and plus or minus if you have space, that's a more advantage to have better resolution. And these things are complementary, coronal better evaluation to have the pseudomeningocele very perfectly evaluated, and diffusion, I felt that diffusion weighted MR is more important to see the one-shot assessment for the respect to the supraclavicular plexus and sagittal shoulder as a screening to see for the denervation changes, which already Dr. Adnan showed you the quadrilateral syndrome. This is the old conventional way of imaging of the brachial plexus within the scalene triangle. You can see the brachial plexus starting from the spinal cord, going between the antiscalene and the medial scalene, and coming out of this spinal cord, and it can damage. And this is the olden way or conventional way of imaging the brachial plexus, supplemented by the sagittal use, where between the scalene muscles you can see the roots here, all the 5 roots, and follow it with the trunks and retroclavicular with the divisions and the cords posterior, lateral, posterior, and superior, medial around the distal subclavian artery and axillary artery. And this is the important technique or data set which I always acquire this map in a 3D scene and try to squeeze it and try to compare with the opposite side and try to get this screenshot to get the what part of the brachial plexus is involved. This is the most important where we can evaluate the direct brachial plexus on the both sides, compare from opposite side and evaluate to the wide field of coils from the center of the spinal cord up to the axilla. So this is the best sequence which I feel this TERMIP and try to get the screenshots stored and try to evaluate with the opposite side and get where it is exactly injured. So this is the way we get oblique coronal images. And this is also, I feel, there's a very beautiful sequence, oblique axial images, where you can see this brachial plexus now from the spinal cord going all the level up to the axilla. This is the way we have to do these oblique axial images in the fluid sensitive sequence. Coronal myelogram best suited to evaluate the pseudomeningocele. And this is the T2 drives coronal and axial sequences where you can see these rootlets, intradural part of the brachial plexus with the dorsal or ventral rootlets injury, and you can always compare with the opposite side where this present or not in the post-traumatic cases and try to evaluate for the missing roots here. And this is the sagittal for the skinning to evaluate the denervation changes, whether the suprascapular nerve entrapment or injury or total brachial plexus involvement with total denervation edema of the total rotator cuff muscles or quadrilateral plexus syndrome, etc., etc. Now we'll see a few of the cases. Before that, what are the types of injury which we can get? This is a normal nerve diagrammatic representation and an avulsion, which is the preganglionic injury, and the rupture is the postganglionic injury where the nerve is discontinuous, and a neuroma is nerve is still in contact with some granulation tissue formation as a neuroma here. And the most important injury, which is really a little subtle and patient will have a symptom, is the stretch injury. It could be a focal involving a root or a couple of roots, or it could be a diffuse where it can involve the total brachial plexus injury. These patients can be managed with conservative treatment, but sometimes even the imaging shows normal, the patient is having symptoms. So this is the area where the new generation MRs are going to get a picture where they evaluate the brachial plexus at the fascicular level. So how much serious is my brachial plexus injury? The preganglionic, more proximal is more serious. Root avulsions are more serious. And they are not going to have a good outcome if there is an old age and a long duration of the symptoms. So this is my first case, 11 days birth injury. You can see this pseudomeningocele here. This is a serious injury. This patient is not going to recover from his Erb's paralysis. This is a very, very important aspect which we ought to mention in our brachial plexus. This is another 26 years male, left neck injury showing direct visualization of the pseudomeningocele, multiple levels. This is a serious injury and this is a poor outcome or prognosis. You can see this is a large pseudomeningocele at multiple levels and going up to the level of the divisions. This is because this perineural sheath which covers here at this particular, they go and converge here at the level of the divisions, because the nerve plexus is going to converge at the level of the divisions. Again, it's going to divide along the cords and nerves. So these pseudomeningocele can extend up to the divisions and then divide going along to the cord. This is the best way that all the nerve sheaths are going to converge here at the level of the divisions. This is a hypothesis which can be explained by this pseudomeningocele of so much large nature here. Multiple pseudomeningocele, you can see the nerve root within that, nerve root within that. And the root avulsion injuries, the dorsal and ventral, one of the important early signs, if you're able to miss the small tiny pseudomeningocele in your regular conventional data set, try to look for this denervation edema in the paraspinal muscles. And this is the very important earlier sign to pick up the brachial plexus injury. This is involvement of the multifidus muscle which is supplied by the end nerve, so that there is a denervation edema in this particular paraspinal muscle. This is a very, very sensitive marker to say that there is a preganglionic injury, especially the dorsal roots. And you can see this injury at the exit zone of the brachial plexus here or within the spinal cord. Blooming in the GRE sequences says that hemorrhage within the spinal cord, they can injure anywhere from within the spinal cord, root exit zone, or preganglionic injuries or postganglionic injuries. You can see this denervation edema, the slide which I showed earlier, and if you give a contrast, this is going to enhance. And this is a tricky situation. We have a single nerve root brightness because of perineural nerve sheath edema or whatever it is on your fluid sensitive sequences. This is a history of trauma, so this is a focal stretch injury. Same, another example, you can see this. This is no history of trauma. This patient is also having a similar symptom. This is a neuritis. And another important component case which mimics a confusion is the osteophyte compression on the brachial plexus, which also gives the same type of increased in that particular nerve root. So we have three differential diagnoses of single nerve root hyperintense signal. It could be trauma if it is a focal stress injury. If no trauma, it's a neuritis. If there are no osteophytes. If there are osteophytes, it could be due to osteophyte compression on that particular nerve root. You can see this fractured clavicle in this 40 years female, and you can see this normal brachial plexus on the right side. You can see the diffuse stretch injury. Total plexus is bright, thickened, and increased signal fluids is sensitive sequence. This is the diffuse stretch injury, nerve injury with continuity. There is no discontinuity anywhere from the starting from the spinal cord up to the axilla, up to the nerves. It is total diffuse stretch injury. This can also be managed. Previously, they say up to 6 months, 3 months to 6 months. You can see conservatively, but latest literature says if the patient is not going to recover within a month, they are not going to recover. You have to intervene. 20 years male injury, you can see this discontinuity of the right upper trunk and beautiful upper trunk discontinuity and diffusion weighted images, and this oblique axon with the upper trunk discontinuity you can see beautifully. This is another brachial plexus injury. You can see through and through brachial plexus cut in the supraclavicular level. Supraclavicular location is the most common location of traumatic brachial plexus injuries. You can see through and through cut of brachial plexus here, and the wavy brachial plexus here. This is known as accordion deformity. This is, once you see this wavy brachial plexus hanging on your MR, that is total brachial plexus, totally cut because there is no continuity. So these are another total sharp knife injury here. You can see this sharp cut of the brachial plexus in the supraclavicular plexus. You can see in the opposite side it is absolutely normal. Here there is knife injury and total through and through cut, very sharp injury along with these contusions of adjacent soft tissues. And we saw the supraclavicular plexus injury. Now we can see the retroclavicular plexus. The fractured clavicle here in this 23 years old. You can see this fractured clavicle, and just beneath the clavicle, you can see the sharp cut of the brachial plexus, discontinuity. You can see the diffusion weighted image discontinuity. You can see in the oblique axial image discontinuity. This is the retroclavicular plexus, which is discontinuous and injured because of the fracture of the clavicle. You can see the same, and you can see this denervation edema in the shoulder girdle muscles. Because the divisions, the most compacted area, if the injuries are going to be very, very serious at the divisions, once there is a cut at the divisions, total brachial plexus is gone, and you have denervation edema changes all over the brachial plexus. You can see this iatrogenic, there is a post-cervical lymph nodal biopsy in the 70 years male patient for a lesion in the left apex. You can see this. The nerve is continuous, but it is like a tumorous appearance. This is a neuroma formation, post-traumatic injury in this particular case of iatrogenic during a lymph nodal biopsy. This is an interesting case where the dialysis technician goes a little bit more aggressively to put a catheter into the IJV, injured these particular soft tissues and went out of the vein, and you can see this hematoma here and injury of the brachial plexus here. This is iatrogenic injury. You can see the hematoma, blood fluid level, and various stages of the hematoma causing the compression on the brachial plexus in the supraclavicular level. And another case of 35 years as post-traumatic injury. You can see this lot of hematoma. We saw the supraclavicular plexus, we saw the retroclavicular plexus, now the infraclavicular plexus. At the level of the cards and nerves, you can see the hematoma here, compressing the brachial plexus, extensive compression. You can see the hematoma, you can see the muscle contusions, and you can see the beautiful nerve with the perineural sheath, and you can see the compression areas here. So this is the extensive compression of the brachial plexus in the infraclavicular plexus involving the cards and nerves. And a companion case, always to remember how is as most of the times the carcinoma breast is post-radiation treatment in this 40 years female. You can see this lot of myositis post-radiation, and this can involve always try to have a look at the brachial plexus to note for a radiation injury. You can see this perineural sheath edema and thickening of the brachial plexus at the site of radiation along with this myositis. This is a radiation injury of the brachial plexus. And coming to the areas of denervation, you can see this, if there is a lot of plexus involved, most of the plexus involved, or majority of the roots are involved. You can see this denervation edema in most of the muscle fibers around the rotator cuff, deltoid, infraspinatus, teres. Most of the muscles are getting involved in this various multiple areas of involvement. And you can see this in this 28 years male patient. We have the discontinuity of the brachial plexus here and the denervation atrophy here. You can see this denervation atrophy and a little bit of edema in the shoulder girdle muscles. So this gives a clue that once the atrophy is there, this is a chronic brachial plexus injury. This is a case which Adnan showed you, teres minor and deltoid atrophy. He showed the denervation edema, that the acute stage. I'm showing the chronic stage of it. You can see this axillary nerve injury producing the chronic denervation changes in the deltoid and teres minor muscle. Quadrilateral face syndrome. And in this particular 23 years male patient, you can see the denervation edema in the supraspinatus and infraspinatus, and with a large spinal glenoid node cyst, which is causing compression of the suprascapular nerve entrapment. Sometimes you have only infraspinatus nerve entrapment, nerve to infraspinatus is entrapped. So here we have only denervation edema only to the infraspinatus after giving a branch supraspinatus muscle. So the extent of the spinal glenoid notch or suprascapular node cyst is going to give a clue that there is a nerve is injured. So finally, the management of brachial plexus depends upon the degree of damage. The site of injury is supraclavicular, retroclavicular, or infraclavicular. More proximal, more serious is the injury. And the site of injury, whether within the card or root exit zone, or preganglionic injuries, which are more serious. And the type of involved roots, various roots. And the time interval between injury and surgery, this is very, very important. As the time goes more, the prognosis is very, very less. And the type of injury also gives, the nature of injury also gives a clues to what to do, whether it's nerve grafting, or neuronal transfer, or neurotization. Go back and put this neural root into the spinal cord, all these things decided by our prediction and our report of where exactly the nerve is injured. The take-home points, look for the STIR sequence, which is the best sequence to look for the perineurocyte edema and nerve thickening, and use your MIP very widely, and try to squeeze and screenshot the images to compare with always opposite side and see for the direct and indirect sense of injury, pseudomeningocele, nerve ruptures, continuity or discontinuity of injury, and also the indirect sense of denervation, edema, or atrophies, and level of abnormality. This is very, very important to see the prognostication and the nature of abnormality. More important aspect is, now I am saying this present generation 1.5T. These images are from 1.5T. If you have a 3T and 7T, we can see the intravascular levels, increased signal within the nerve root in your axial image to the nerve axis. So that is the reason I put this last sentence. Even if MR negative, they can be patient have symptoms. So if the patient has symptoms, better use for electrophysiological studies to say that there is an injury of brachial, to confirm the brachial plexus of injury. So MR negative studies doesn't exclude an injury. Thanks a lot.
Thank you, doctor. This is the end of the first session in the morning. If there is any questions for the speakers.
Question to Dr. Fatima. It's just about the athletic rheumatology. If we do probably imaging, pelvis imaging for almost all of the soccer player, professional soccer player, you will see some changes, and most of them actually they do have the secondary sign. And most of them we do image them for other reasons, mostly muscular tear. We include the pelvis and still you see it. Sometimes it's very hard to draw a line about which one is really significant when it's not significant, because you see it in all patients. These
on the clinical picture. Actually, I had one of my significant changes at the sample. He was totally asymptomatic in the sample. And the adductor rectus femoris, but he. And when I asked him, are you having midline pain or problem? He said, I'm absolutely fine. I have no problem at all. So I don't put much significance on it if the patient is not symptomatic, because most of these patients with such movements, they will develop some changes at the symphysis of pubis.
I do think most of the soccer, especially the soccer, they will have. If they don't, then probably they are not professional.
Yes, many of them.
You're not doing any kind of injection for this area to relax those?
Actually, most of the patients that I deal with are professional players. So go to the team, the treating team, and they are the one who take care of them. But you know, the PRP injections can give good results and healing of these tendons.
But you do have a trial of PRV in this area with them?
I personally did not.
Okay.
Especially the professional players, they do have their certainty.
Yeah, certainty.
Okay, is there any other question?
Thank you. And first, just to thank all the speakers for this morning's session. The quality of lectures was absolutely brilliant, and everything from all the speakers. But for Dr. Prasad, about your protocol for the brachial plexus, because you had really beautiful images. Do you routinely do the axial as well as the oblique axial, and the coronal as well as the oblique coronal sequences?
Yes, whatever the data set I showed you, I do completely. But the only hitch is if the patient is not cooperating. In the acute injury, of course, in very acute setting, you are not going to evaluate brachial plexus anyway. I hardly encountered any patient not going to get all this data set. Till today, I have more than 240 collection of traumatic brachial plexopathy, one of the largest series from India. We evaluate a lot brachial plexus trauma. All the cases we were able to do all the data set. Sometimes I took out of diffusion because in my system, beyond the supraclavicular plexus, it's very, very tough to get the resolution, good resolution to evaluate the brachial plexus beyond the divisions. So sometimes I exclude that, but most of the times I do all.
Oh, okay.
One question for all the organs. It's just general for probably the musculoskeletal radiologists who read athletes. I'm not sure, you have seen probably lots of classification for the muscle strain and muscle tear. Is there any preferable one that you guys use in general, or? I personally start to prefer the British way, because it gives you lots of...
Yes, exactly. Most of us following the British classification of location and extent, right?
So you use the 4 grades rather than the 3 grades.
Yes.
And you go with it.
Elaborate things. But the only hitch is it is given for the only lower limb, right?
Yeah.
Paper is for the lower limb. Calf muscles, most of the times. But you may not, whether we really doubt that it can be implied into the other areas. That is the problem. That the British classification that was given mostly to the lower limb.
Yeah, for the just audience, the British classification goes with grade 1, grade 2, grade 3, and grade 4. And it does address the involvement of the myotendinous junction, the tendon, central tendon, and the myofascial plane. So it goes in both longitudinal and circumferential involvement. Thanks.
Okay, thanks for all the speakers. And now we're gonna end the first morning session. And you can go for the break for 15 minutes, I think.
Yeah,
10 minutes. Okay.
Session will start at 10, inshallah.
Mine. It's okay. I'm going to attach the...
See, this is when. Oh, that's that one.
It leaves very tasty. Very tasty. Thank you very much. And very important. But firstly, okay, please come. You're very smart. I want to respect on this. I don't want to teach on this.
لا اسمعش بس يعني واضح
What time you want to go?
طبعا كبير ربع ساعة. عندهم यार वो माइक लेके आ
चला सही से तो और नहीं चल रहा है काम करो आसपास बोले
बोलो ऐसे उठाए गया बोलो उसमें ऐसे बोलो करिए आवाज मार के रखना पड़ेगा
कोई बात नहीं सेट कर रहा है
ऐसे रहेगा तो सही है वो तो आराम से वो आराम से कम नहीं है तुम सही बैठो 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 सही है एक्सरसाइज करके दोबारा से उसके साथ बताऊँ खोल के मुझे लगेगा मोबाइल में टायर बता देता मोबाइल में जबरदस्त समझा कि मैं स्नैपड्रैगन इक्यासी से पूछा 8100 8000 स्नैपड्रैगन 4000 स्नैपड्रैगन उसके अंदर 8100 कुछ है स्नैपड्रैगन इससे तो 800 कुछ है बस नहीं वैसे यार 5000 12 GB रैम है उसका तो खत्म अभी तो लोग बस काम करते हैं क्या घर वालों को बोला पापा घर में मोबाइल घर वालों ने बोला पक्का करो उस महीने में मोबाइल लेगा ये बात तो हुकूमत को बोला बहुत समय
We asked him, you sleeping?
After I come back from the mall, I don't have to sleep.
Just one way.
My car, Uber last night.
We are going to Lulu.
Yeah, yes. It's called Lulu. Oh, that's Lulu. It's called Lulu hypermarket. Maybe you're going there later. Oh, okay. Maybe that's the morning.
That's the one, right?
So I think we are ready to start the second session for the day. It's internal derangement of the ankle and other joints. The first talk will be by Dr. Stephen Wong, foot and ankle ossicles. Dr. Stephen Wong is the head of Department of Radiology at Sing Kang General Hospital. Dr. Stephen Wong. How do I change that?
No, I'm just the cameraman. I don't. What do you mean? Please.
Practice. Oh, he's coming. It's okay, yes. Apologies for the technical difficulty. Assalamu alaikum, konnichiwa, good morning, sawadika. Okay, so it's my honor to talk about ossicles of the foot. These are my disclosures. So ossicles, as we all know, are supernumerary bones, usually normal variant, thought to be unfused primary or secondary ossification centers. Sesamoids are also structures you see in the foot as well. They're actually osseous structures that are embedded in the tendon. That's the main difference between sesamoids. So there's a question, which ossicle is this? Is it A, os, tibialis externum? I put a circle there, okay? But the answer is actually all are correct, okay? So unfortunately, different people have named the ossicles differently over time, causing confusion. So what to me is os tibialis externum, to you may be a type 2 os navicularis. Okay, so there are 24 types of accessory ossicles. I've only had 15 minutes. I originally was going to do 1 minute per ossicle, but I'll try and rush through. Okay, so we're all quite familiar with this standard diagram of all the different types of ossicles in the foot. Obviously, the ones I've highlighted are the more common ones, and those the ones that I'll be concentrating on a little bit more. Okay. Incidentally, while preparing for this talk, I thought it was going to be an easy topic, but when I started looking through the x-rays, I realized that I only have about this 5 or 6 types, and the rest are almost impossible to find, because they're extremely rare. Okay, so let's talk about the os trigonum. Okay, so as we know, posterolateral to the talus. Some thought it to be an unfused posterior tubercle, or even a non-united striatal process fracture. Easily the most commonly seen. Best view would be on a lateral knee X-ray. You can see it posterior to the talus. Okay. MR usually shows the separation between the ossicle and the talar bone. Okay. It was thought to have involvement in the posterior impingement syndrome. The other name is the painful os trigonum syndrome, where you have you end up with degenerative changes at a synchondrosis. Another differential is the shepherd's fracture. So this is a case I have where you actually have an os trigonum and you got a shepherd's fracture at the same time. Next one is the os peroneum. This is actually within the peroneus longus tendon. So in reality, you should actually call it a sesamoid bone rather than an ossicle. It exists in a cartilaginous form in everybody, but becomes ossified in about 25–26% of us. Generally round and ovoid, and in appearance is close to the calcaneal-cuboid joint. It can easily be mistaken for an ossicle that I'll show later. Again, you can have a painful os peroneum syndrome as well, where you have localized tenderness, perhaps due to injury, tear, damage to the tendon, or it's just compression by foot weights. The next is the os vesalienum, or pedis. Now, this one is within the peroneus brevis tendon. Usually it's slightly posterior to the os peroneal ossicle. You have and is proximal to the base of the fifth MT. So the main way to differentiate is to follow the posterior brevis tendon, which is here, and over, and you can see that it's embedded or close to the posterior brevis tendon. So I find sequential MR images helpful to differentiate between the os peroneum and os vesalineum. This is a fairly rare ossicle, the os intermetatarsus. Most people actually think that it's just an avowed bone fragment that's not fused. It has been mistaken for lip spring fractures in the past.